So thank you for a really warm welcome to Emory, and thank you for everyone who's here today. So in the next 45 minutes, I plan to talk about my journey in global health, and I want to specifically point to the things that I've learned along the way, and that the lessons that have really shaped who I have become today. I'm going to focus on my work on building a transition intervention. To give you just a snapshot of some of the work that I've been doing, this intervention supports transition from transitioning adolescents from pediatric or adolescent-oriented care to adult HIV care. And then I'm going to talk about my experience with mentorship, teaching, and service, and then hopefully summarize key points of why Emory would be a good home for me. So I was born and raised in Kenya, and growing up, the one really sure thing I knew I wanted to be was a doctor. I wanted to be a doctor, I wanted to work with children, and I wanted to improve their health. My family didn't know anyone who was a doctor. We didn't know anyone personally who was a doctor, but I didn't really know what I was getting myself into. But all roads for me led to the University of Nairobi Medical School, one of the 2 medical schools in Kenya at that time. But after I began my clinical experience after the training, I started becoming very frustrated with some of the gaps that I saw in clinical care. I felt that, I knew what to do from a medical training, but I wasn't able to do the things that I had learned in school to do because of the gaps in clinical care. For example, there were sometimes guidelines that had changed, but it took so long for the guidelines to actually get to the ground. And I got very, very frustrated. So after 3 years of clinical practice, I decided to, find something else. I enrolled in a Master's of Science in Tropical and Infectious Diseases. I thought that maybe I'll just go and become a lab scientist. I'd actually chosen virology as a specialty area to go into. And I thought, I'll just be talking to my samples and not really have that connection with the frustrations that I saw on the ground. However, as part of my practicum, I was attached to a research clinic. And this was an experience I actually really, really enjoyed. It was a sex workers outpatient clinic where they were doing HIV research, but they were also providing services. And what I really liked about this experience was that I could ask questions and systematically answer them to improve health. And that really helped me fill in that gap that I had been looking for. And so at the end of this program, I applied for a clinical research position to work with one phase 2 vaccine study. And this was a large collaborative grant that included multiple research partners, where I got to meet very exceptional mentors who have continued to be my mentors today, Dr. Grace John Stewart from the University of Washington and Dr. Dalton Wamala from the University of Nairobi. And then I also got to really work very closely in my role as a study physician with Gwen Ambler, who was an MPH student at the University of Washington at that time, and who was project coordinator for that study. So I really got very good clinical trial experience in this study. This was a rigorously monitored clinical trial. So there was a lot of procedures that I needed to learn and really grasp how to do a clinical trial in Kenya. I got experience working with the large collaborative teams and working on research products. But the part that I really, really enjoyed from this study was the weekly calls with the PIs. They helped us build that culture of scientific curiosity. We are asking why was the norm. We were always asking why. For example, I had a lot of children who came into the clinic with neutropenia. As part of the research study, we had to monitor adverse events. These kids came in with neutropenia, which is a low level of a certain white blood cell, and I wanted to understand why. And with support from the team, I wrote my very first author manuscript while I was working with this team. And by the end of the study, I had really enjoyed and engaged so much with this study that the PI team agreed that I should first author the primary outcomes paper that was published in Vaccine in 2014. So that's how my journey really began. And so after this study, I jumped onto another role as a study physician coordinator for a new trial. And this one was, the name of the trial was Pediatric Urgent Start of Heart or PUSH study, which was also led by the same mentors. And I got to meet Dr. Lisa Cranmer, who's here today. This was almost 10 years ago. And Lisa Cranmer that time was a pediatrician doing an MPH studies at the University of Washington. And Lisa and I co-led implementation of this study. The goal of this study was to understand whether urgent HIV treatment could be given to severely ill children. And this was in the context where the standard of care was to hold treatment, treat the opportunistic infection they came with, and then initiate HIV treatment. But this approach often led to delays initiating treatment. And in the meantime, a lot of children died. And so our hypothesis was that if we start treatment early, while they're in hospital, they can recover a little bit faster, and maybe they will have better survival. But again, we had the cons of potential challenges with implementation and the risk of immune reconstitution inflammatory syndrome. And we had extremely high mortality. I mean, this was a study powered for mortality. We had extremely high mortality. Of the 183 children we enrolled, 39 of them died, which is about 21%. Very, very high mortality. And what we found was that even if we started treatment urgently, there was no survival benefit. As you can see with those curves there, you see we track very well both the urgent arm and the post-stabilization arm. But what we found from the study is that initiating treatment in the hospital, because there was no difference in the arms, was actually safe. So instead of waiting those long delays that had been there initially, where people would wait for so long before they initiate treatment, clinicians could confidently initiate treatment even while the child was still hospitalized. This work was published in the Lancet HIV, and it was one of the two studies that provided evidence for the 2017 WHO guidelines for treatment initiation in children with severe illness, where the WHO emphasized that initiating treatment early was actually safe, even when the children were still hospitalized. And so as we did the PUSH study, there were many new questions that arose. And these questions motivated new analysis. The new analysis motivated even more new questions. And so some of the questions we were asking was, who are these children? Why are they coming in so late in their disease? And how or why has the system failed them? Because we knew we had a robust prevention of vertical transmission system. How had that system failed them? And for this, I worked with another MPH student at the University of Washington, Angela Wagner this time. We worked on a paper together that looked at the care cascade of these children, trying to identify where along the cascade were they missed. Is it that their moms were not tested for HIV? Is it that their moms never initiated treatment, or where along the cascade did we miss them? And this was some of the initial work that really built the evidence towards incident maternal infections being a really key contributor to new infant pediatric HIV infections. We also asked questions about the HIV diagnostic algorithm for children. Some of our nurses, as they were testing children in the ward, had questions about whether the algorithm was working the way it should. And these questions prompted new analysis. We did a very important analysis that identified that infant HIV serology tests. So for example, when a mom came in and her HIV status was unknown, a child came in and the mom's HIV status was unknown, then what the clinics would do, or what the hospital would do, is that they would test the baby with a serology test, and they would use that test to determine exposure in the baby. But that approach completely missed quite a number of children. And these results actually led to change in the guidelines so that we're no longer using infant serology tests to determine maternal HIV status. We also wondered whether we could find these children before they land in hospital. Part of the work I shared on the system gaps, we identified that about a quarter of those children who we had enrolled in our study had been seen in an outpatient setting a month before they landed with us. We know that mortality was highest in the first 2 weeks of life. And so then in the first 2 weeks of admission. And so then we were like, what if we had found them 2 months earlier? And is there a way we can address those gaps that led them not to be tested within the hospital? And so one of my other colleagues looked at work around, what are the gaps, what are the barriers to pediatric HIV testing? And one of the ideas was that maybe because it's very complicated for families, people are talking about it's just hectic for me to figure out how I'm going to take my child for testing and the costs of that and barriers related to cost. And we wondered, could we motivate parents to test their children for HIV testing, which was the basis of my MPH work at the University of Washington. So I got a small grant that was by the International AIDS Society. It's called the CIPHER Growing the Leaders of Tomorrow Fellowship Program that provided about $150,000 for a period of 2 years to answer this question. Could financial incentives motivate parents to test their children? Today, instead of testing them tomorrow, because we were really focused on, making sure that these children get tested as early as possible. And we found that they did. When we gave incentives, you can see that graph there, at our highest incentive amount, which was equivalent to about $10, we saw quite a number of children were tested, 57%. But again, disappointing, because we never really got to as many tested as we wanted. But we did see that improvement in testing. So I remember when I was, unblinding this study, and I was very excited. Yeah, this is something, we'll take to the ground. People will use this. At least we'll test over half the children who need testing. But it was very disappointing, because there was a lot of skepticism about scaling up a financial intervention. And I see Deb here, she told you that. So this wasn't something that people were excited about. We couldn't get the Ministry of Health in Kenya, people who had known before, to even think about it. And so they didn't think that this was a way that we could improve testing. So we still went ahead, published the results, presented them in many, many international forums. But again, too, we couldn't get policymakers to consider scaling this intervention. WHO commissioned a systematic review to support their 2019 HIV testing guidelines. And I led the section on financial incentives, the review of the data on financial incentives, which showed that incentives actually improve HIV testing, but they didn't endorse incentives. So we had an intervention that I thought was good, I thought was effective, but it wasn't sticky. And so there was something wrong about the way we approached this study, and something different that we needed to do to make sure that we build sticky interventions. So this was something that I carried forward in my journey. And so then another question we asked was, can we optimize testing to find children earlier? Can we go to the outpatient where children are in the outpatient setting, and try and test every child who comes to the outpatient setting? Maybe in that way, then we'll be able to improve HIV testing. And some of the questions we asked is, can we make testing easier for children by using a saliva test? At that time, saliva tests were not recommended for children who are less than 16 years. Less than 16 years, you couldn't use a saliva test. And we even went ahead and thought, maybe you can even give the parents the test, and they take the test home and test the child, so that it's even more convenient. And so Anjuli again and Chido, who was a Zimbabwean colleague, all of us were now, we're all early stage investigators, very excited with this work. Chido had been funded separately. We were funded also separately, but we combined our data to answer these two questions. So what we found was that the saliva test was highly sensitive and specific for using children. And there wasn't a reason not to think that, but we needed the evidence to show that it was effective. We also found that this was using data from Zimbabwe and some of the qualitative data we did in Kenya, that caregivers could give the test. They were interested in doing the test. They could correctly collect samples. They could manipulate the test kit, and they could also accurately interpret test results. So this was good. This is what we were looking for. And we published this work in JADES. And then we started working with OraQuick, who was the company that provided for us the saliva test. And that data was, and then we worked with them and shared our data with them. That data was submitted to the World Health Organization, and that led to expansion of pre-qualification that allowed saliva testing for children aged 2 to 12 years. But you notice here, the recommendation was that this test should be given by a healthcare provider, not caregivers, as we had initially thought. And even though we had that data that supported caregiver testing, and we wrote many policy briefs, we had lots of discussions with CDC and WHO, we couldn't get policymakers to endorse caregiver testing. They were worried about the risks of violence or harm to the child. And there wasn't evidence of that, but they just couldn't endorse caregiver testing. And it was only in 2020, because of the COVID pandemic, PEPFAR, in a technical guidance, made this temporary adaptation where ministries of health could consider providing parents with test kits so that they could allow HIV testing to continue during the COVID period. So was it sticky? Probably. It was sticky, kind of, but maybe not as sticky as we would have wanted. And so then I carried, this experience to the next phase of my PhD. to the next phase of my journey, which has included my PhD work, my K work, and then also with the new R1 that we recently got funded. And this important lesson for me has been that good ideas don't necessarily translate to policy. Have to think about how those ideas will translate into policy. And this period has, I have changed my focus a little bit from more pediatric stuff to more adolescent stuff. And I must say, I didn't really plan to go that way, but I was very motivated by the children who I had bonded with in the earlier push study and children who are existing in other cohorts who we had bonded with and become friends with them as they came to the clinic. And I saw that these children were aging into adolescence. And then there was evidence coming out that these children were actually not doing so well when they get to the adolescent period. So why are adolescents living with HIV unique? We know that there are about 3.1 billion children, or 3.1 million adolescents who are aged between 15 and 24. The WHO definition of adolescence is 10 to 24, but it's very hard to get data that is 10 to 24. Often it's 15 to 24 or 10 to 19, and that's, a data gap that we need to address. And this population is very unique because it's composed of two different groups. There are children who are aging into adolescence. Pediatric HIV treatment has done really, really well. And these children are now being able to get into their adolescence years. But then we also have very high incidence of HIV among young people. We know that young people contribute to almost half of HIV infection. This population sometimes is very difficult to differentiate in program settings in a lot of low and middle income countries. We also know that the adolescents have poor clinical outcomes across all steps of the HIV cascade. And so this is a graph that comes from UNAIDS. Again, we have challenges with data disaggregation because we don't have such a nice graph of how it would look like for adolescents aged 10 to 24 or 10 to 19. And what you see here, the first three bars there show, you can see the children who are living with HIV, and they're looking at the dark green is those who know their HIV status. The red is those who are on treatment, and then the lighter green is those who are virally suppressed, which is what you want in the cascade. And when you look at those graphs for children, these first three bars represent data for children. That includes children 0 to 14. So again, data problems, we're not able to get the 15 to 19-year-olds. Then look at the adults on the other side, the women and the men. You can see quite a number of differences when you look at when you compare that to the children. And data consistently points to gaps. If you just look at the adolescent population, gaps in in care across all steps of the cascade for this 10 to 24-year age group. So other outcomes, when you think about retention, we know that the adolescents have lower retention overall. And they also have specific groups within that adolescent population. Newly enrolled adolescents seem to have significantly worse retention when you compare them to those who are already enrolled in care. For example, this was work we did that looked at program data from Kenya among 4,000 adolescents who are aged between 10 to 24, where we found an almost 8-fold higher risk of loss to follow-up. 8-fold higher risk of loss to follow-up among those who are enrolled in care in the past 2 years compared to those who had been in care longer. So another really, really huge drop-off for adolescents. Then when you look at mortality, overall mortality among adolescents is estimated, among adolescents living with HIV is estimated to be about 3%, which is quite high for a population that is supposed to be young and without a lot of other comorbidity. And mortality is also higher among newly enrolled adolescents in care. So again, using the same program data, we found a 2-fold higher mortality among newly enrolled adolescents. And lastly, for viral suppression, again, this is program data showing data from over 10,000 adolescents in 99 HIV clinics in Kenya in 2019, and where we found that over a quarter of adolescents were not virally suppressed 6 months after they had initiated treatment. And that's the time where you expect them to be virally suppressed. And when you look at across studies and across settings, this is pretty consistent. Adolescents have really poor clinical outcomes. Some of the key gap areas that, in adolescent HIV care, and this was some of the areas that were identified in an expert meeting in 2016, and particularly for children who are growing, from pediatric to adolescent care, was really challenges in that transition process. First, the lack of effective tools for disclosure. How do you tell a child who was born with HIV? How do you tell them that they have HIV? And how do you build tools that you can actually integrate into programs to support that? And then once you do that, how do you then transition them from pediatric, adolescent into adult HIV care? And this group identified that there was a general lack of tools to support transition. They identified that there were models that existed for other diseases, but not HIV. And HIV here was unique because most of the care in sub-Saharan settings is decentralized. It's offered by lower cadre, non-specialist people. And so then, while it's good for coverage, there are challenges with sometimes when you have population-specific needs that may not necessarily be addressed. The other thing they found was that there was a lack of clear definition of what transition is. What is transition in that setting? There was lack of evidence-based interventions, and also problems with data integration. The challenges that I talked about with, what is the cutoff? Some clinics, 12 years old, you're an adult. Some clinics, 18 years old, you're an adult. So all those different challenges were a big problem. And so when you look at sub-Saharan Africa, what is happening with transitional care? This is referring to transitioning from pediatric or adolescent to adult HIV care. And as I mentioned, it's provided by non-specialists, and that can be challenging. So this was a review paper that Daharau, looked at the different models of care that were existing. And he described 4 different kinds of care that were happening at that point. You had clinics where, they had pediatric or adolescent clinics, and then children were moving to an adult clinic. This was a rare model and was only available, in the referral hospitals or the more specialized settings. Then you had integrated clinics where everybody just came and everybody was seen together, whether it's a child, an adult, or an adolescent, they were all seen together. And then you had this model, the integrated family-centered model, where people would see families together just for convenience, and also to provide holistic care for the family as a whole. And then there was this youth-friendly transition clinics that were quite common, where youth would move together in one group from, they transition from the adolescent or pediatric clinic together, and they would transition together to the adult clinic. But what they found was that all these methods, all these transition models were really dependent on the clinic and the resources that were available, and none of the models had evidence on outcomes. So when you look outside sub-Saharan Africa, there's very strong evidence that structured transition programs are associated with better post-transition outcomes. This is an example of a tool that was developed in the US, the GOT transition tool, and GOT advocates for a stepwise transition plan supported by a multidisciplinary collaborative clinical team. And there's different steps. Have a policy, monitor and track, figure out readiness to transition, planning, transfer of care, transfer completion, and there are multiple steps and multiple people involved in each of the different steps. Very nice age-based, process that you can easily follow. And I remember looking at this for the first time and thinking, how this works? How are we going to do this? How are we going to do this in Kenya with all the different models of care? How do you move something like this and actually make people want to use it? And so this is a slide I got from an online talk that was given by Dr. Gregory Aarons, who's a lead implementation scientist, that really hits the nail on the head on what works. Here, every picture represents a version of the main idea, but only one of those pictures is useful, what the user wants, the one in green. And when you think about research projects, sometimes at the beginning of the research project, sometimes the ideas are completely different from what actually ends up, working, what was submitted to the sponsor versus what actually was done at the end. And it just helps us think about, what the user wants is actually what you're really trying to get. And how then do you get to the green box? So this is where, implementation science comes in, and, it's a learning curve for those of us who started off in EPI, trying to figure out, how do we get to that? But implementation science frameworks, for example, this process framework called the EPIs, helps you think about the end at the beginning. So you start with the end in mind, yeah? And it recognizes that phased approach to implementation, where you consider multi-level stakeholders, values, knowledge, and their experiences. And it can really help optimize uptake and sustain use of an intervention. So this framework has 4 different steps. It's exploration first, preparation first, implementation, sustainment, and you keep going back and forth until you really get what fits for the setting. And so with that background in mind, I had the privilege of being the project director for this study. This was the ATTACH study that was looking at transitioning adolescents from adult care to adult care for adolescents who are living with HIV. And our objective was really broad, to improve the process of transition from dependent to self-directed care. And we wanted to develop tools, first for disclosure, which is a prerequisite for transition, and then for transition, so that they could be able to successfully get to adult care. So there were 3 broad objectives of the study. First, we wanted to understand what is happening on the ground, what are clinics doing. Then we wanted to develop a tool and an implementation strategy for that tool. And then we wanted to test that tool. So this was just one arrow one, but it looked like 3 different studies. And this is a good example of where what was in the grant was completely different, because as the steps evolved over time, then we kept finding different things, and the different things informed what we were doing. So for our first objective, we collected data. We found 102 large volume HIV clinics, and collected data from them. And what we found was that many clinics had what they called an adolescent clinic day, which was a day of the week that was dedicated for adolescent care. So we pick a day like Wednesday and say Wednesday is adolescent day. Adolescents would come on that day, but it was not necessarily adolescents must come on that day. If an adolescent came on a different day, they would still receive care. And then we also found that transition definitions were very heterogeneous. Most clinics people had their own definition of transition. Sometimes it's when you get to 18, you have to move, that's transition. When you get to 24, you have to move, that's transition. Some clinics even had 12. Like the Leatoto clinics that some people here have worked on. At 12 years, you had to move to the adult clinic. We also found that there was a lack of tools to support disclosure of HIV status, and something that providers talked about, an adulting tool. How do you help adolescents adult so that they can be able to, be independent in their care? There was also limited ability to track process. And this was important because we looked at the Ministry of Health tools that were available, and the Kenya Ministry of Health had this adolescent checklist that was supposed to be used at every visit with adolescents. And the checklist had just 2 questions that were related to disclosure and transition. First question was, has disclosure been done? And then you just indicated a partial or full disclosure. And then the second question was, has transition preparation begun, yes or no? But there were no tools to support any of that. And so that was a challenge because providers didn't want to disclose. It's difficult to disclose. Caregivers also didn't want to disclose. And so there was this delay in disclosing HIV status. We also did a lot of qualitative interviews with healthcare providers, with adolescents, and with caregivers. And what we found was that healthcare workers talked about a desperate need for a disclosure tool. They really needed support to figure out how to disclose. They also needed this tool for adulting, which they referred to as something that helps adolescents learn about managing medication use, understanding what HIV is, figuring out adherence strategies, and also gives them some information on sexual health. They also wanted some guidance to figure out what is readiness and how do we say somebody is ready to transition or not. And they warned us, if you give us something cumbersome, we will not implement it. And there were some nice programs that I had looked at, some nice books, so people had developed toolkits that had pictures, and people would carry homework and the kids would go do homework at home and then come back and bring it to the clinic. And the experience from that clinic that had used those tools, they said they can't do it. This will not work with the workload that we have. And so the question was, how do you develop something that provides the knowledge and skills adolescents need for that next step, but then also fits the system? So what we did was we put together a stakeholder team. And how we selected this team was very interesting. We actually went to the Ministry of Health person who was in charge of adolescent health. And I mean, we were lucky because that was somebody who was very interested in improving health outcomes for adolescents, and asked them, if you are going to develop a transition tool, who would you invite to the meeting? And they gave us, this partner, that partner, this partner. And we looked at that list and worked on it together and worked on the dates for our workshop together, and then brought these people together, about 40 people in all. We also included adolescents, and we also included their caregivers, and specifically frontline health providers who we thought would be the ones using this tool. And so within this group, we reviewed the existing tools. I showed them the GOT transition framework. We brainstormed on what transition definition in our setting is. How do you even define it when you have all these models of care? And then we also talked about how a transition program would look like. This is one of the products of that workshop. So we developed this framework for what transition could look like in our setting. This could work in Kenya, it could also work in similar settings. And it included a process, again, similar to what we saw for the GOT transition that had age milestones. There was caregiver engagement, which was a piece that we thought was really important. Partnerships with adult providers, where the adult providers were different, because in most cases, the providers for adolescent, child was the same person. But the critical role here was for how the pediatric and adolescent clinic could provide adolescents with the knowledge and the skills that they needed to successfully navigate adult care. So this was really what our definition was, making sure that adolescents have the knowledge and the skills that they need to navigate adult care, regardless of which model of care they were in. And that tool was figuring that out would be something that would work across the different models of care that were available. And so to address disclosure, which as we said is a prerequisite for transition, we adapted this toolkit that we found that had been developed in Namibia. So this was a booklet that talked about, the title of the booklet was Why I Take My Medicine, and it came together with a disclosure readiness assessment to assess the caregiver readiness for that disclosure to happen. And it also came with a disclosure tracking tool because it took time. It took about 2.5 years to go through the whole booklet with the children and for them to be ready for that actual disclosure. And together with a smaller group of people who are in the initial stakeholder workshop, we adapted this tool to fit the Kenyan context. So this booklet uses the metaphor of the battle of infection to describe HIV in the immune system. It describes HIV as the bad guy, body soldiers as the immune system, and HIV medicine as a blanket that keeps the bad guy asleep. The bad guy would only be named in chapter 5, and only when the child and the caregiver were ready. This process in Namibia took about 2 years to complete, from the time you start to the time you get to full disclosure. And sometimes it would just be repeating concepts until the child was able to understand. And then for the adulting tool, we developed a transition booklet. The booklet was named Taking Charge, and it came with transition readiness assessment and transition tracking tools. This was fully co-developed with stakeholders in Kenya, and we had a very heavy youth engagement, and youth were actually engaged in looking at the graphics. Do these graphics look okay? They suggested the tool name. We had initially called it Growing Up, and they came and told us nobody likes to be told to grow up. Was the name that they gave, and they also suggested the picture up there with the key, the key with a kind of depicting a healthcare worker giving the adolescent the key to their life to really take charge of their life. So this is really helpful for me to also understand how important youth engagement is, and this is something that's actually shaping the next steps of my career. And the other thing we did was that we used the Ministry of Health artist for the graphics, so that this booklet could also look like what the Ministry of Health publishes, because with this something we were hoping that they would take up and use. So the Taking Charge booklet consisted of 4 chapters, and these were really focused on knowledge and skills in 4 key areas: HIV literacy, self-management, communication, and support, which is what people thought were the most important things that adolescents needed to learn. And this guide was presented in the form of a booklet or a flip chart that had key information, questions to prompt discussions, and punchlines. The punchlines, again, were suggestions from the youth. For example, better late than never. in the discussion about what to do if you forget to take your medicine. And the problem shared is a problem solved in the chapter on communication. So we tested this intervention in a hybrid one cluster randomized trial design. This is where you're more interested in whether it's effective, but you're also collecting some data on implementation. This was done in 20 HIV clinics in Kenya, and we specifically tested just the transition piece. We did not test the disclosure piece because by the time we were getting to this point, we had very little time left in the life of the grant. And so we couldn't test the transition piece. Plus, there were issues with COVID and disclosure just couldn't happen the way we had anticipated. And so the primary outcome was a transition readiness score that was aligned to the chapters in the booklet that was assessed at enrollment, month 6 and month 12. And then we also looked at secondary outcomes of viral suppression and retention, and then the implementation outcomes. So our intervention showed significantly higher transition readiness scores in the intervention arm in red compared to the control arm in blue. And specifically, we had significant changes in our HIV literacy and self-management domain. Overall retention in the cohort was pretty high, so we didn't find any differences by arm, and neither did we find differences in viral suppression, even though there was challenges with collection of viral suppression data. Some of that happened during the COVID period. That data was also published in Lancet. And so to understand implementation, we used the consolidated framework of implementation research and to guide our qualitative interviews with health providers. And overall, adolescents and healthcare workers really liked the tool. They found it acceptable, they found it feasible, and they found it easy to implement. And some of the things that they specifically liked was like the pictures. So the pictures enhanced comprehension. The language versions, we had different language versions depending on the population that we were working with. They liked the adolescent-friendly language, and they also liked the fact that it could be implemented by many different cadres of staff who are working in the clinics. This is some example quotes from a youth living with HIV who talked about, sometimes I forget to take my drug, and then I remember what the book says, and then I'm encouraged when I take my drugs. Or this healthcare worker who said, the tool helped them take charge when they're talking to the client. They had a place to begin a conversation with the client and to talk about the client issues. And so post-trial, after the study ended, our eyes remained on the price, which is a sticky intervention. So we brought back that group that we had in the stakeholder group. We got some additional funding, brought back this group, and shared with them the study results. We did many presentations at any national meeting we could find, and also did policy briefs for the Ministry of Health. And the highlight of all this work was that the Ministry of Health started seeing us as a transition people. And we got invitations, like, for example, this was when they were reviewing the guidelines. They asked us, I got an email that said, can you review this transition chapter in the guidelines? And so then you feel that, okay, our work was making impact. And they were interested in implementing the tools too in the national program. 1 year post-trial, and this is something that usually doesn't happen. When the trials end, a lot of times you've run out of money, trial ends, and there's nothing more you can do. But we were lucky because we were able to get additional funding through some networks and to go collect some data 1 year post-trial. And this is data that's been led by two students from the University of Washington, an MPH and a PhD student. And they looked at what was happening in the clinics 1 year later. So by this time, the intervention clinics had been giving the intervention for 2.5 years. The control clinics had been giving the intervention for about 11 months. And part of the protocol was that we would give the control sites the tools to use once the study ended. And overall, people were still really excited about the tools, and they wanted to continue using them. This is a quote that really inspires me. This healthcare worker said, but I must say that the person who did the disclosure tool and the transition tool for ATTACH, I believe that somehow this person involved the primary healthcare worker or the provider, because it was really simple, unlike how I expected it would be. So I think we had finally got to sticky, which is what we were looking for. And so then as a continuation of this work, we recently received funding to partner with the Ministry of Health and to now scale up this intervention, but really think about a strategy for scaling up that really engages youth. So we will have a youth-led data-driven intervention where youth will review data, we'll train them to do data audits, and these are youth who are part of the regular healthcare system who are included to support adolescents in HIV clinics. And it will also include some CQI work and collaborative learning opportunities among the youth who are involved in the study. And this is actually the first R01 grant that I have that I will be serving as multiple PI. So I think in summary, this is what I've learned, starting with the end in mind. And I was very resistant to frameworks because implementation science has frameworks, theories, models, all these things floating around. I kind of sometimes can get lost in the weeds, but I think they're very, very important to help us think about the end in mind. I think it's also important to think about engaging until you become the face of the intervention. So tailoring, figuring out who do I need to engage with. For us, it was the youth, it was the healthcare workers, and it was the system. And then really presenting the results at multiple stages so that then we're still part of we are seen as the face of that work. So I've shared with you a taste of my research, but I just wanted to highlight other areas of my research portfolio that has included HIV testing and treatment. Some of the work I've shared was around testing and treatment, interventions to optimize outcomes, but also across different infant and child populations, those with HIV and those who are exposed to HIV, which is an area that I've recently started working on. So these are projects. We love logos. I think it makes you like bond with the study when you make a logo, you feel that ownership. And so most of our studies have, these logos. These are the studies that have served a big role, and these studies were really critical to helping me get the scientific skills that I needed to move on in my next career and in my next steps of my career. And some of those we've talked about earlier on. But then my focus has more recently been on this group of studies. And I have 4 studies that are funded that focus on adolescents, and 2 of them that are pending review. So the 4, the one that says afya elewa. Elewa is a Swahili word that means understand, and zingatia is actually zingatia is like afia. Yeah, those 2 words are Swahili words. But for those 2 studies, I'm really interested in understanding who are these adolescents who are dying and why are they dying? And part of that work was to do mortality audits with families to understand what are the circumstances that led to the death of the adolescents, just to try and understand whether there are things we can do to improve the system to be able to identify them early. Zingatia is now looking at those adolescents, and one of the things we've noticed was that there are some adolescents who are just persistently non-adherent. They come to the clinic and all the time they say poor adherence, poor adherence, poor adherence. So everybody knows they have poor adherence, but we're not really able to find out how to support them. So we're doing some photo voice work to understand what motivates those adolescents in Zingatia. Timiza is a work from my K43, and Timiza focuses on supporting adolescents in the school environment. In most sub-Saharan African countries, boarding schools are pretty common, and boarding schools, they tend to be much more resourced compared to other schools, and they tend to be more of the better high-end schools. And so a lot of, when we're doing the attached study, caregivers and adolescents would say, I don't want to go to boarding school because if I go to boarding school, then I'll not be able to take my medicine. So there's that, they actually, we want them, we have helped them survive, but we are not able to help them thrive because of that challenge of boarding school. And so I wanted to work with schools to see how we could build some interventions to support them and what the gaps in the school environment are. And then I've talked about the attached study. Two grants, the stigma grant that's pending review, November 18th, that grant comes directly from the work in the K, because the K work just showed that stigma in the school environment is really, really prevalent. And there are ways we could address stigma in that school environment that not only focuses on adolescents living with HIV, but also supports adolescents who are HIV negative to accept HIV testing, because we know incidence is also pretty high in that group. Then there's another grant called I Take Charge that hopes to make the attach intervention and eye intervention, make it e-health and e-health intervention. And that's something that we're working on with brands, and on who's here, so thanks Brian for coming. That grant didn't score really well, but we're not discouraged. We will submit it again and see whether we get it. And then there's this new studies, these other 3 studies focus on child or adolescents exposed to HIV, and we're trying to understand neurodevelopment in those children at a population level. That last study, the RISE study, and it's a U19 mechanism, which is very, very large corporate grants, cooperative agreement grants, and this brings together 9 US institutions and 5 sub-Saharan African countries to understand interventions and to also understand mechanisms for poor outcomes among children who are exposed to HIV. And so I hope I've given you a nice idea of my journey and a snapshot of my research. I'd like to talk about mentorship and specifically highlight some unique mentorship approaches that I found very helpful for my career. So as I shared my journey, I talked about the role of peers or near peers, people who are doing MPH, who are in the MPH program, who I could consider my peer or near peer at that time, and who had research methodology expertise, but didn't have clinical and contextual expertise. And I've been able to really bond with those people to work together to improve my skills, but then also to support them get the clinical expertise they have done. And my relationship, for example, with Angela Wagner, with Lisa Cranmer here, really shaped that initial steps of my career. And when you look at our, I just put this to show how my career has tracked that of Anjali, who's a US-based student. She had her MPH in 2012, that's around the time we met, PhD in 2015. She got her K award in 2019 and got an R01 in 2023. So that just shows how much that relationship has been helpful for me and to help me really get to my career. Because sometimes it's very hard for us who are from, when you've grown up with a certain kind of mentorship, it's very hard for you to talk to the senior mentor. The near peer mentor really helps you develop the ideas before you refine them and are able to share with the senior mentor. The other thing that I found very helpful is group mentorship. And I have a group mentorship team that we've met over the past 6 years, where we have a weekly Zoom call. And here we talk about professional development, we talk about science and works progress. And the idea is to make it a safe space for people to come and bring things, whatever they have, that we can discuss and talk about. We also have a buddy system, which we thought about, like, this comes from my relationship with Angela. Maybe we could pair 2 to 3 people strategically and see if they can work together to support each other. And sometimes it works, sometimes it doesn't, but where it works, the relationships are really strong. And then when we think about other students, I think within the projects that I've worked in, for example, as project director, I try to earlier on in the grant, plan for what types of data, what types of analysis could come from this work. And then I have some broad ideas, but when students come and they need a project, then I'm like, okay, these are the broad ideas, which of these would you be interested in? And then link them to different mentors who can support them. And for example, this is one of the large studies I've worked on that had, this was a unique study because we had about 6,000 participants. We've had 5 MPH students, 5 PhD students, and 1 undergrad student. All of them get some experience within this study. And within these connections, there's also mentorship happening within here. For example, Helen, the first person there, Helen is predominantly a qualitative researcher, but she wants to learn about quantitative methods. And so she's working with Delaney. They're working on a paper together that looks at growth data from this cohort. So even within these groups, there is some very unique mentorship that's happening that's really will spur somebody else's career growth. So in terms of teaching, I've given multiple guest lectures on a wide range of topics in global health, both at the University of Nairobi, the University of Washington. And more recently, I have started linking up with Emory. For example, I gave a talk 2 weeks ago on building community partnerships for equity in global health. And I'll be giving another talk next week. And I've also worked with the School of Nursing on grant writing training that they're doing. So in terms of service, I co-lead the Social Justice Working Group at the University of Washington. And we've had some very tangible products from this group. We've developed guidelines for equitable authorship, equitable budgeting, and we're currently working on figuring out how we assess partnership health within our groups. I've also contributed to papers that look at advocacy for equitable global health research practices overall. Other important contributions to, generally to the research field include review of global health proposals. I'm now an NIH K43 grant reviewer, and I also reviewed Gilead Global Awards. And I'm also a member of the International Maternal Pediatric Adolescent AIDS Clinical Trials Impact that aims to evaluate potentially new treatments for children, adolescents, and postpartum. So why am I a good fit for Emory? I think I've demonstrated scientific expertise in pediatric and adolescent HIV, a strong commitment through the examples I've given to build interventions that work. I have strong writing skills based on my publication records and also my research grants. I have strong project management skills. I have served in 8 studies as either PI or a PD. I'm a committed mentor. I haven't shown my whole list of mentors, but I do really engage a lot in mentorship, both for MPH and PhD students and F31 students. Very collaborative. I like sharing ideas and working together to solve solutions. And finally, I'm committed to equitable global health practices. So I would just like to end by acknowledging the many faces of the individuals I've worked with over the years. These are the real faces of global health, and really appreciate the contribution they have made to my career, as well as to the many people who have supported me today, especially my primary mentor, Dr. Grace John Stewart, who coincidentally is giving a talk right now at the immunization conference here in Emory. Thank you, everyone. Thank you.
We have about 5 minutes, and I know that some people may have to go. So we have probably time for 1 or 2 questions. Kamini?
Hi, I'm Kamini. I'm one of the second-year PhD students. One of my research interests is HIV care. And, I've looked at some research related to the transition in pediatric care here in the US. And I guess I'm curious about, with your disclosure, the booklet specifically, how you kind of describe HIV as the bad guy. I'm curious if that kind of has an impact in terms of stigma related to HIV for the kids that are reading that story, because just thinking about as a child, if I were hearing that, I would want to know why do I have the bad guy, or what did I do kind of a thing. And so I know you said you weren't able to look at disclosure in the first study. And I'm curious if you have any thoughts in terms of if you're going to look at it in the future.
Yeah, that's a very good question, because that actually never came up in the work that we did, even with the stakeholders. But I think as we move on to the next step and think about scaling, that would be something really important to bring up. So thanks for that. Thanks for that question. Yeah, it's really important.
Yeah. No, it's such a lovely presentation. I enjoyed the beautiful narrative of the work that you've been doing. I'm wondering about your thoughts about sort of differentiated vulnerability and risk among pediatric populations and adolescents, and if you could speak to kind of issues around intersectional vulnerability, particular groups that are marginalized based on your experience.
Yeah, and that's something that our group or my work hasn't really focused on, but again, really important to focus on. There are groups within the adolescent population that have unique needs. If you think about the younger children, the children who are orphans, they have unique needs, and they're living in homes that sometimes are quite unstable. And then there's also the older children who also have unique needs, because some of them are, there's laws in Kenya about sexual orientation and disclosing that. And so this is a whole very complex group of people that is really hard to look at with one lens, and figuring out how to balance, we were thinking about the sexual and reproductive health chapter in our booklet. It's actually a page that talks about sexual and reproductive health, figuring out how to balance what the government will allow us to put in the book versus what people actually need, and figuring out how do we then acknowledge that, the government doesn't want us to talk about this, but maybe figure out a way that we can help providers. This would be an opportunity for you to ask those questions. So I think that's really important to think about individual adolescents. But then as you're developing a tool for a program, then you have to figure out first what works for everyone, and then now identify the different values and try to address.
It is just about 1 o'clock, so I'm not sure if you have another meeting at 1 o'clock on your agenda. I was looking for your agenda. 1:15 lunch. Oh, lunch with the PhD students. Okay.
I guess, yeah.
Okay, well, I think we can close it since it is 1 o'clock. Was there a question from Kate? Who has the Zoom? Okay.
Well, I have it.
Do you? Okay. Are there other questions online? I don't have the Zoom, so I don't know. It is here. It's on this main computer.
Sheila, did you want me to speak up?
Oh, there we go. Yes, yeah, that would be great.
Okay. Thank you, Irene, for that wonderful presentation. I wondered if you could talk about how in your work you have addressed the different needs of adolescents with behaviorally acquired versus perinatally acquired HIV.
Yeah, that's another really important question. And so as we're developing the transition intervention, we were thinking about the whole population of adolescents who are living with HIV, those who were perinatally infected, plus those who have acquired HIV. And these groups have different needs. But at the bottom line, what we really tried to focus on for intervention was, what do they need to know? What are the skills that they need to gain? So we made an intervention that combines the populations, but we acknowledge that these two populations are different. But in terms of what they need to know, what they need to gain, I think you could think about it as the same, pretty much the same needs. But I agree with you, again, sometimes in program systems, it's very hard to identify the two groups. Sometimes adolescents are first diagnosed when they're 12, and maternal HIV status is not there. So within the program, it's hard to know who's perinatally and who's not. And so we didn't really distinguish the two groups. But I agree with you that the pediatric acquired HIV do have unique needs even in terms of their growth and their future potential.
Thank you.
Suba, I think you had a question. Did you want to go ahead and?
Oh, I'll close it out, I guess. So I was really, I loved all of the community engagement work that you did. And I was just wondering if you could speak more about how you overcame a few of the challenges, not all of them, I'm sure there were many, but like maybe one challenge in kind of identifying or like connecting with certain folks during your community engagement.
Yeah, some of the challenges were really around who do you invite and how do you make sure that you have a guest list that covers everybody who's in pediatric and adolescent HIV. And one approach we did was, the Ministry of Health has a lot of meetings, focused on adolescents. They're changing guidelines, or they're developing a strategic plan, or, there's all this activity happening in the ministry that focuses on adolescent HIV. And so we wanted those people who go to those meetings to be the ones who come to our meeting. Of course, by the time we scheduled and all that, there's a lot of challenges with making sure that everybody is able to come to the meeting. And so what we did was that we had the group of 40, but we kept it open so that if the ministry decided that there was somebody who was really important, we also included them in the smaller groups. Smaller groups were then the ones that finally developed, came up with the final tools. And there was also an opportunity to come back to the second workshop, the dissemination workshop, for those who are not included in the original workshop. In terms of the youth, and I know youth engagement is also a problem here, because sometimes you want to make sure the voices of youth are heard. So when we had our small groups, when we had the workshop, the youth that we got, were youth who are already seen in the ministry as national figures, people who can talk about HIV confidently. We made sure that their voices were heard during the workshop. But then after the workshop, as we developed the tool, we specifically worked with adolescents. The adolescents are the ones who looked at the booklet, looked at the material, figured out whether this works for them. And we asked them to even go and share with other adolescents who are not part of the team and who wouldn't even want to be part of the team. So in that way, we thought that we had actually engaged as many people as would be possible.
Thank you so much.
Thank you. Thank you also everyone on Zoom. And close it out and